probably should know by now.
Yeah, Catherine will know for sure. So the popliteus muscle. Do you guys? How often do you guys check this muscle when you get someone with knee pain? Do you guys ever look at it or kind of assess for this muscle when it comes to when someone does come in with knee pain?
Like everybody should, but oftentimes, yes.
There you go. So we got the popliteus muscle. So basically, the trigger point is refers in the back of the knee. So whenever someone has pain in the back of the knee, uh, you're definitely going to look at the popliteus muscle. But from my experience, also anywhere along the knee. Like for example, today I had two cases. I had two cases of knee pain come in, and both of them had issues with the popliteus muscle. It's not the standalone. It's not the only muscle, as you'll see. It's not the only muscle that is kind of the culprit of that knee pain, but it can be definitely a big part of the knee pain that that person's experienced, depending on what the mechanism of injury. So patients rarely present with knee pain solely from the popliteus muscle, but it's a component. Initially, knee pain is often misattributed to can be misattributed to trigger points in the gastroc and the biceps femoris. And then after treating both of these muscles, the pain can still be kind of lingering pain. And the thing is with the popliteus muscle, one of the things with it is that it presents as meniscus type pain, like deep knee pain. And now once I show you guys the attachment points of that muscle, you'll kind of have an understanding as to why, because it's very deep muscle and it's often connected to the meniscus as well. So often when people come in, they get diagnosed with meniscus tears, this, that, and we all know by now that when it comes to surgeries, doing surgeries on meniscus and going and doing arthroscopies, it's not the thing that the surgeons are doing anymore. Very rare. I mean, I've had in the last like 3 4 years in the last 5 years I've had one case where the surgeon, and this was a surgeon that retired last year, he did that surgery, the arthroscopy and kind of cleaning out the knee. So it's something that surgeons don't do anymore, and most of it is treated conservatively because of the fact that the meniscus heal, and then also a lot of times that meniscus type pain can be attributed to these muscles. So it's very important to when it comes to your guys' schooling, how much of that did the school kind of focus in and teach about the popliteus muscle or the origins and insertions, or not too much? Okay, so there's no feedback because I was talking to one of the RMTs, and they were saying that there's really not much on the popliteus muscle, but it's like I say once again, it's huge when it comes to dealing with knee pain. As you can see, it's a triangular flat muscle forming the floor of the popliteal fossa. So the floor meaning it's very deep, so it's very close to the joint, and it has a big impact on the joint. So it's very important to treat and look at. It's anchored proximally to the lateral femoral condyle and knee joint capsule, so it connects with the knee joint capsule. So that's why it's a very, very important muscle. And distally, it attaches to the posterior tibia, so it's right here. So there's that above that soleal line. Key attachments: wide-shaped ligamentous connections. It's always present in the femur. And one of the things that I never really realized until I was looking at this diagram is that you could see that popliteus kind of starts at the tibia and then it goes around that lateral part of the femur, of the lateral part of the tibia, and then the femoral condyle, and it actually comes and it attaches in the mid part I always thought that this guy goes kind of up here, the way I was described, the way the people in the IMS course especially described it. It kind of goes up, and we were even dry needling up here. And you can see, but which makes sense that it would have this type of alignment and this type of origin insertion just because of the fact that it's responsible for locking and unlocking the knee. It's almost responsible for the rotation aspect, which is why it would kind of wind around like this and attach into this area. Now, a lot of patients, when they come in, they present with, and this is the front of the knee. So the kneecap's taken off, and this is the front of the knee. So this is why this is so important, is because of the fact that this guy kind of attaches underneath the kneecap. And how many patients with knee pain that come in complaining of pain under the kneecap? It is so common. So common. But the reason why this popliteus could be implicated in that, imagine, it coming underneath the kneecap and attaching here, and then this part having tendonitis. And this is why it's so important to look at this muscle in behind the knee, even though the pain is kind of under the kneecap. So this is what I found very fascinating about this diagram, because it kind of shows the popliteus insertion to be very kind of, something that I wasn't really thinking. I thought it was more like kind of up here type of thing. So it's very, very cool in that sense. And then the palpation part is according to Travell's sign. Travell book. It's the best to kind of palpate it around this area, but I often even palpate it through here, palpation wise. So you can palpate it anywhere along this area, and it's usually when that muscle is quite inflamed, it's not that hard to palpate it. Function and actions: medial rotation of the tibia when the leg is free to move. So meaning in the sitting position, it's responsible for medially rotating the tibia. Lateral rotation of the femur on the tibia when weight bearing. So unlocks the knee for movement. And it's a weak knee flexor, so it doesn't actually do much. Much in terms of knee flexion. So key function: stabilizes the knee during a bent knee, semi-crouch position, preventing the forward femur displacement. It's also responsible for active heel strike during the gait to unlock the knee for weight bearing. And it's inactive during standing. So the reason why this is so important is because this is when you ask your patient, when does the knee hurt? Does the knee hurt when you're going into that squat position? Does it hurt when you're running at heel strike? Which because in that way, when they say, hey, it hurts as soon as I land on my heel, it starts to hurt, then you have an idea. It's like, okay, well, it could be the popliteus as well. Or when someone's getting into that bent position. Works with the medial hamstring, sartorius, and the gracilis for medial leg rotation. So this is very important because of the fact that about, I would say, 70 to 80% of the knee pain, a lot of times it is happening on the inside of the knee. So once again, it's important to look at this muscle even when the knee pain's on the inside. The muscle spindles help monitor knee locking and unlocking, aiding in joint stability and coordination. So this is very important because of the fact that a lot of times, and we're so guilty of doing this as well, as soon as the patient says, my knee is not stable, right away, what do we think? We think ACL, we think of all the ligaments. But a lot of times, because of the fact that this muscle is so important in stability of the knee, and when this muscle is not functioning very well, it's going to give people that feeling of instability. Symptoms of the popliteus trigger points: pain in the back of the knee when crouching, running, or walking downhill. So if you have anyone, any of these avid hikers that are coming in, so important to look at the popliteus. When crouching, I had a patient come in that's he does flooring, and he's crouching all day long, right? So anyone with their knee bent can be an issue for sure. Rarely causes night pain or noticeable knee weakness. So if you're doing a test on knee extension and flexion, so you're not going to notice it as much because it's very deep. Once again, it often presents with that capsular, ligamentous type pain that's very deep inside the knee. Differential diagnosis. So a common one is this Baker cyst. So many people, I feel like this Baker cyst thing is overdiagnosed. I mean, they go to the doctor a lot of times like, oh, you got a Baker cyst. Like, what the hell does that even mean? Why is that cyst? People don't even know what that means. A popliteal vein thrombosis, meniscus tear. So very common. Avulsion of the popliteus tendon. Trigger points may be overlooked due to the deep location. So once again, if you're a therapist, try to get in there and try to look at this muscle, because of the fact that even though people have meniscus tear even on imaging, it's once again a lot of times, is that meniscus tear causing the pain? That's the $1 million question. Or was that meniscus tear there before the pain? Popliteus tendonitis, tenosynovitis, same thing. It's caused by overload. So someone that's increased their running, their whatever activity that they're doing in the gym, can go that can all cause the popliteus tendon to and the pain is felt at 15 to 30 degree of knee flexion during weight bearing. So if someone's squatting in that first 15 or 20 degree, or as soon as they start kind of going down, the knee pain starts, you have a good indication that it could be the popliteus. So the differentiator between the Baker cyst and the popliteus is that Baker cyst causes swelling, trigger points do not. So if there's a lot of swelling that's happening, or the swelling's kind of going down into the leg where the Baker cyst burst, then it's a true Baker cyst. Ultrasound helps differentiate, and ruptured cysts may mimic thrombolybistisis. There we go. And so when you guys, quick question about the Baker cyst. When someone has a Baker cyst, how do you explain to the patient what that is? Anyone?
Meniscus tear causing fluid to leak into the back of the knee, and it forms into like a fluid-filled sac.
Yeah. So any sort of inflammation within the knee can actually cause the bulge in the back of the knee. So that's a good one. Anyone else?
Pretty much the same thing. Any degenerative changes creating fluid to leak out into the space.
Yeah, exactly. So people don't understand because they think the cyst is like, they don't even know why it's there. They think it's like pathological. Like, people are scared when they hear this Baker cyst. So essentially, Baker cyst can happen because within the knee joint, there's only so much space. So that fluid needs to go somewhere, because very small amount of space, and it doesn't take much fluid in order to immobilize that knee joint. So the fluid's got to go back, but also sometimes this Baker cyst can be caused by bursa behind the knee, where basically, for example, the bursa for the hamstring, the bursa for the gastrocs, there's bursas within that area as well that can also swell up and cause that feeling of Baker cyst. So that's another thing that can cause it. So anytime the knee's feeling unstable, the popliteus is very important in stabilizing the knee. So in addition to looking for these ACL, PCL, ligament tears and stuff like that, also the popliteus is very, very important for stabilizing the knee. And another thing, so if someone does have an ACL tear, you can imagine that translation of the femur on top of the tibia is going to be a lot more. So there's going to be less overall stability, which is going to yank on this muscle, creating more tendonitis and more inflammation. And a lot of people are going to come to you complaining of knee pain, and that knee pain might not necessarily be from that ACL tear itself, but from the amount of stress that this popliteus has to do to stabilize the knee. So often when those patients come in, I work actually on their popliteus a lot because I know and their posterior muscles, because of the fact that those guys are going to be more strained. And after I work on those muscles, they actually feel relief because the, those muscles kind of get reset and there's not as much inflammation there. So popliteus tendon injuries. So basically, MRI may misinterpret normal popliteus tendon as a meniscus tear. Popliteus tendon avulsion ruptures are reported in pushing a car, sudden change of direction in sports. And then surgical repair, they do it sometimes, but I think it's very, very rare. Maybe in like top level athletes, they might do stuff like that. Activation of the popliteus trigger points, sports, activities, soccer, football, running, skiing. So pretty much anything, sliding, twisting, uh, running, skiing downhill. So all these injuries that are synonymous to ligament tears also can impact the popliteus. Muscle overload, this is very, very common. Breaking forward motion of the femur on tibia, twisting, turn with the weight on slightly bent knee. So these are right away people think the worst. They think, I tore my ACL, I tore my MCL, all this stuff. Where a lot of the time, and I had a patient today, same thing. He described to me all these like crazy, my knee went this way, went that way, did this. But the reality of it is when the patient comes in to see you, you got to try and then, after the session was done, he's like, man, my knee feels actually a lot better. But all I did was just work on some of the other muscles, but mostly a lot on the popliteus because it was just very, very inflamed. So after working on that muscle, that takes away, 70 to 80% of the pain. Not to say that he doesn't have any other issues that are happening there. Potentially he does have some ACL and whatever tears that he might show on imaging. But the bottom line is when the patient's there and, we can wait for the imaging because sometimes imaging takes 5-6 months, but we don't want that patient continuing to limp and have pain in that knee. So related injuries that can trigger points is plantaris muscle tear and PCL tear as well. Can strain and overload the popliteus, and I think also the ACL tear as well can have an impact on all those posterior muscles, not just the PCL tear. And so plantaris, any sort of even gastroc tears, any sort of tear can also cause the trigger points to occur in the popliteus. And even the last couple months I've seen, even like with myself, that the trigger points from the gastroc can easily cause knee pain. So anyone that has knee pain, definitely look at their gastroc muscle as well. And this is an interesting one. So foot mechanics and trigger points. So the popliteus muscle, if someone has excessive foot pronation during weight bearing, if you can imagine that rotation, so as soon as they weight bear, they're rotating that leg kind of rotates in. Well, what that's going to do is that's going to create a lot more stress on this muscle. So someone that has excessive foot pronation can also have trigger points and inflammation within the popliteus. So someone that has excessive foot pronation, you also want to, and is kind of feeling some knee pain, whether it's on the inside or the outside of the knee, you want to check the popliteus as well. So commonly linked trigger points is the proximal gastroc. So anytime someone has you feel like their gastrocs are tight, or vice versa, they have knee pain, you got to look at the gastrocs. And then the plantaris muscle tear. I actually think I had this tear, this one or the medial gastroc, and then since then I've been having knee pain, which I think is largely the popliteus muscle that's causing knee pain, as well as the gastroc muscle trigger points. And since I've started foam rolling and working those guys out, because even my knee pain, kind of honestly, at some point I thought, I'm like, man, I must have some meniscus or like some, because the pain was so excruciating when I was turning and twisting and doing like squatting and things like that. But after I've worked out the popliteus as well as the gastroc muscle, my pain's actually subsided quite a bit. So it's pretty cool to kind of, even, you don't think much of it, but once you have knee pain, you realize how debilitating the freaking knee pain can be. Lateral gastrocs can cause pain and motion restriction in the popliteal fossa, similar to the popliteus trigger points. So the bottom line is, anyone that has knee pain, you got to also look at the gastrocs. Support and protection, wearing elastic knee sleeve, that can help as well. Avoid immobilization. So we don't want people wearing immobilizers and things like that. Gradual conditioning of the muscle before skiing or high impact activity. Avoid sudden increases in downhill running or walking. Avoid high heels. Limit running on sloped surfaces. And proper shoe inserts if needed. So what I've done here, what I'm going to do is I'm going to enlarge this a bit. So what I've also done is I've kind of done a video showing you guys how I find the popliteus muscle. Now everyone can have their own ways of finding it. So when it comes, ready? So when it comes to the popliteus, that's where the muscle is, right in there. Best way to get at it is prone, knee bent, and you're right in there. Trying to work that out. Right in there, because it's right above the soleal line. It's right in there. And kind of follow it right through, because it runs right across the knee. Is there any ways that you guys try and find the popliteus? Any other positioning that works for you guys? So what I like about this position is that it takes the tension off the muscle. So the muscle belly is kind of free, it's not taut. And that's why I like it being prone in a little bit of a bent position. And then what I do is I go to the inside. This is where most of the muscle belly is. It's on the kind of inside, and then it goes into a little bit into the popliteal fossa. So once I find that spot, I just press and I hold. And you can hold up to even 30 seconds at that trigger point. And then often people will get pain kind of in the back of the kneecap, kind of deep inside the knee, which is probably right in here, because that's where that muscle goes right across, right through, and then under the kneecap, because in this diagram they've taken the kneecap off. So people experiencing pain in here, when you press in the back there, it's a good chance there's the popliteus muscle. And then here is a little bit more medial, very superficial. Me doing the dry needling on it. So same position. I have it. I know Harin does it a different way because he's dry needled me before, but this is kind of how I do it. Very superficial. And then I kind of go, and you can see a little bit of a trigger. You can see there's a bit of a twitch there. Yeah. Did you guys see that little twitch that happened right in here? And sometimes I even go a little bit more medially because I'm trying to get kind of in there. Go a little bit more medial. Very superficial. And I try to go superficially. I'm probably getting a lot of the gastroc, but there it is. So you saw that big twitch right there that happened. And when that twitch happens, I'm palpating, and that twitch does kind of run across. It's not a twitch that I'm activating the gastroc down here. It kind of runs across. Runs across, and it goes right across the knee like that. Good. So any questions, guys? We hit about a 30-minute mark here. Any questions? Anything you guys would like to add? So to summarize, anyone that has any sort of knee pain, anyone that has, twisted their knee, the knee came in and came out, or whatever the hell the patient describes, or the knee feels unstable, please look at the popliteus. And one of the most interesting things, like I say, that I found was that I always understood, this is where the attachment spot is, but I was not aware that the origin of this muscle goes all the way across, back, and it attaches. I always was under the impression that it kind of attaches somewhere up here, and that's where even in gun IMS, we were kind of dry needling up here to find the spot. We weren't dry needling up here for the proximal part, but it goes right across, and it actually attaches into here. And that's what makes this muscle so significant when it comes to knee pain, because you can see it meshes with the lateral meniscus quite a bit, because it's a very deep muscle. So it's always so important to look at when it comes to any sort of knee pain. And I had 2 cases, and both cases had active popliteus trigger points. It wasn't just the popliteus; there was other things involved, but this makes a big part of that. The reason why they're coming in with that knee pain. So always please take a look at that muscle. And then as you can see, the way I'm dry needling and doing all my work, my knee's bent. And a lot of the time it's my right knee, and that's one of the reasons why I've started getting more right knee pain as well. As I've kind of valued in my own biomechanics, and the knee being in a bent position for so long, that's one of the reasons why what causes the symptoms of a popliteus trigger point is that knee being in a bent position for too long. So anyone that describes their they've come in with knee pain because of the fact that they're they're crouching for too long, or being in a bent position, their knees in a bent position for too long, that will cause that trigger point in the popliteus muscle, in addition to all these other things. Any other questions? Anything you guys would like to add?
Thanks, Milan. This has been really helpful. Just one question. Do you find with these clients, their knee extension is limited at the end range?
Sometimes, yes. Yeah.
But not always? So sometimes popliteus can be an issue, but they still have full range?
Yeah. No, for sure. It can. Yeah. Because it's a weak knee flexor, so it doesn't really the bigger culprits would be the gastrocs, shortening of the gastrocs and hamstrings. But this one definitely, because when the gastrocs is shortened, it has an impact on the popliteus for sure. So if someone is lacking that knee extension, definitely look at it as well.
Okay, thanks.
Yeah. And Jennifer, do you ever dry needle the popliteus?
I do, yeah.
Okay. And how do you do it?
It's usually in side lying, and so you're kind of getting it to it through the posterior border of the tibia, like you kind of push the gastrocs aside.
Kind of right in here, right?
That's right, yeah.
So you're getting more at it in this area here. More kind of at the tendinous part.
Yeah.
Yeah, that's kind of the common way. Like I say, this one, I find in the popliteal fossa, it's it's not something that they teach, but I just find I get such a good release out of doing it, right? Because you get right into that muscle and you get that good twitch.
More medial.
Like you see that right there on that medial aspect. It just you could see that muscle twitching away. So that's something. And like I say, I don't go very deep here because I know there's other structures and things like that. But I do find it does pop quite good. Anyone else? But I've never tried to dry needle it in this area. But based on Travels, it says, best felt between the lateral gastrocs and the biceps femoris tendon. So it's indicating that it could be up here. So I might look at maybe, especially if someone that has that lateral knee pain. And often, if someone comes in with, runner's knee or like IT band type of pain, you also should look at the popliteus because it is kind of on the outside as well, outside of the knee. So looking at it as well. But I'm actually gonna try and see if I can maybe even dry needle it out here, and I'll let you guys know how it is, what the outcome is. Good, awesome. Anyone has any other questions, feedback? Good. Okay. Awesome. Thank you guys. Enjoy the rest of your evening.
Thank you, Milan.